Good morning, everyone. Thank you for coming. We'd like to welcome Dr. Ashish Atreja for his grand rounds of health system transformation through digital medicine. Dr. Atreja completed his internal medicine residency followed by a fellowship in gastroenterology, as well as medical informatics at the Cleveland Clinic. He joined Mount Sinai Health System in 2013 and has since continued his pursuits in clinical gastroenterology with focus on inflammatory bowel disease, recurrent C. difficile, and fecal microbiota transplant. Dr. Atreja continues to revolutionize patient-centered care as director of the Sinai App Lab and Chief Technology, Innovation, and Engagement Officer in the Department of Medicine. Please join me in welcoming Dr. Atreja.
Thank you. It's a privilege to talk about a topic that's so close to my heart, how we can have health system transformation using digital medicine technologies. So thanks for having me. So brief learning objectives. I think once I want to drive home a message, which probably you all know, that value-based healthcare is here, and there's an urgent need for solutions that can help us achieve the outcomes we want to in value-based transformation. And the second is how the new field of digital medicine is evolving just within the last 5 years, and how it's gonna underscore nearly every discipline of medicine we have. So I'm gonna share some of the learnings we had and some of the learnings outside Sinai as well, and to see how we can wrap it all together and make it meaningful for us. So talking about value-based healthcare, this is probably the most underread and underappreciated report that came from HHS. This was in January 2015, and it completely changed how healthcare system executives have been thinking of what to do in the health systems. If you really see, 50% of total payments will be done through alternative payment models rather than fee-for-service by end of 2018. That means the hospitals which have been running through fee-for-service model, the ambulatory practices, the ambulatory surgical centers, all have a risk of losing 50% of their revenue just because of the transformation from fee-for-service to alternative payment models. While this is probably the first instance when the government is really ahead of the health systems, so the HHS created this kind of a vision, and it's actually being applied, but health systems are really, really lagging behind. 76% of hospitals, that's around 2,500 hospitals, around $500 billion of money they lost because of readmission penalty for the hospitals just last year alone. It is estimated half of the hospitals are actually unprepared for MACRA and MIPS and from the bundles payment that's gonna come down the pike. So there's a big gap that we have to fulfill. And this gap cannot be fulfilled by the technology we already have into our health system. It cannot be fulfilled by the electronic health records. We have to look beyond electronic health records to achieve those meaningful outcomes. Just looking at Mount Sinai, this is the data courtesy Robbie Freeman, 2015. We lost $1.3 million in readmission penalty from CMS alone. And just to give a perspective, this is just readmission penalty. There are many other kind of incentives and penalties that are beyond readmission, including for bundles payment, including for MACRA and MIPS, which is meaningful use is going to be transformed to. And this is just hospital-based, not ambulatory-based. If you extend this to private payers, if you extend to all other kind of value-based initiatives, it can actually range into multi-million dollars. In fact, the report from Accenture suggests that hospitals can lose as much as $100 million a year if they don't actually start making a meaningful engagement, including those with the apps. So it's a real problem, and we always had a need to actually engage with the patients outside our health system, and there were technologies there, but we never had a very strong business case to incentivize them. It's the same thing that happened with electronic health record for the last 15 years, right? So EHRs were there. There was an interest to actually electronically get all our medications, e-prescribing, and those kind of things. But there was no strong business case till meaningful use came. And now in 15 years, we have 95% of the hospitals actually have EHR implementation. So how we translate value-based healthcare for some of the residents and others is, if we look at our ambulatory practice, we have patients, and the highest quality care is actually limited to only a segment of the population. These are the patients who come to us routinely, who are very well controlled, who make appointments, and who are very proactive in their care. Any symptom they have, they will call us or send a MyChart message. So we can stay on top of it. And when we see them in our clinic, we pat on our back and say, job well done. You know, this patient is doing really good, meeting all the criteria. And those are the patients we used to get paid, right? Because it's a fee-for-service world. If we see the patient, we drop the code, we get paid. But in value-based healthcare, we suddenly are being asked about patients who are falling through the cracks. These are the patients who may not readily say that they are not doing good, but they are not doing good because they're missing days from their college, they're missing days from their work, and they probably do not know what symptoms are serious enough to warrant immediate attention. So, and we have no way of reaching out to those patients and making them proactive in their care. Earlier, it never used to matter because they may not make an appointment, my schedule is full, the hospital beds are full, we all making money and that's fine. But now, we're gonna be losing money, financial incentive on that. What was good care all along is now becoming a good care with penalty if we don't provide the good care. So there's other layer of patients who saw us and who never followed up with us. When we take at risk for these populations, then if the patient falls through the cracks, doesn't follow up with us, rather gets a surgery in some other hospital, we are still accountable for those surgical costs. And then there are patients who are never correctly diagnosed. These are the people who may have pre-diabetes or diabetes we never picked up. These are the people who may have advanced adenoma, but we haven't reached out to actually do a colonoscopy preemptively. There is no way for majority of our chronic patients to find patients with uncontrolled symptoms where they spend majority of their time, that is at their home at work, and find them and bringing back and bring proactive care. But not only we do not have tools to deliver proactive care when they are at home, we're also bombarded by all these quality measures, right? So we have our CIO Kumar here and CMIO, and there's such a big workforce that's completely dedicated just taking the quality indicators out and fulfilling, right? That's bombarding us. And we do not have tools to report on quality indicators. We do not have tools to provide remote monitoring, but the government is already putting us on the radar screen to say who is doing good, right? So we call it as a triple whammy. We do not have tools, we are just getting started, but we're already being reported nationally how good we are doing on certain arbitrary metrics. So this is what we call as a triple whammy, and we really need tools to address this triple whammy. I'll take a pause so you can go through the cartoon. Right? So we have to dramatically change something. And really we have to go beyond the traditional technologies which were built in 2000, 1990s to really see what are the possibilities now which can make the transformation happen. In some way, EHR has really done a very good justice to us by getting us all to a singular platform and singular technology and a singular workflow. But in some ways, it has narrowed our perspective. We feel the only way to deliver care to the patients in front of us is when they are in the office and we are able to document at the point of care, right? And that is 0.5% or 0.05% of the patient's life when they come to see us. 99.9% is not when they're in front of us, where all those behavioral modifications need to happen, where all those early stage disease have to be detected, where all the modification have to happen post-discharge. And we do not have tools in that transactional system called as electronic health records. So I often take the example of Steve Jobs. There's a lovely documentary. It's only, I think, 20 minutes on Netflix, where Steve Jobs talked about a book he read when he was, I think, 7 years or 9 years, and talking about the efficiency of locomotion among different species on the planet. Basically, how much calories are burned by different species in the planet. And they compared human beings were really way behind. And so it was very pessimistic. But the next chapter was the human being was put on a bicycle. And suddenly human beings were one of the most efficient species of locomotion in the entire planet. And so Steve Jobs thought, we as human beings are tool builders, right? So we can, whatever inefficiency is, we can build the tools to create efficiency. That's how he saw computers as. And that's how we as physician scientists are seeing digital medicine as. In fact, the smartphone you have in your hand is 1,000,000 times more powerful than all the NASA computers in 1969, which let the man land on the moon. It's such a powerful technology which is in our hands. And if you really kind of not break it open, but open it up to see what all is there, it has all the beautiful sensors, and each of those sensors are actually generating a new track or new field within digital medicine, right? The camera which is there is actually our window to telemedicine, right? Telemedicine has been there for 20 years, but it was clunky, Cisco computers, Polycom, $75,000 investment. Now, there's a WebRTC, there's a program, you can run it for free, just using the camera from the phone, right? So it has a voice. The voice you can use to give commands like Siri. So elderly people who do not even have a smartphone interface can actually now use Alexa to give voice commands and get access to some of the health information. There are already tools where you can see if a person is giving a good grand rounds or not based on the voice. They can find the patient when they are depressed, because they have run algorithms when a person is depressed, how slow and how low volume and the pitch gets affected, and when they're excited or normal behavior, how that is affected, right? If you really look at other tools, so they have a GPS right there. The GPS can actually track with near location if the person is close to a hospital. And if you can see if a person is close to a hospital for more than 2 hours, it can give an alert to the patient, hey, are you getting admitted in the ER, or you are here to see your loved one? And if they're getting admitted, you can proactively deliver a care, maybe through telemedicine. So before they actually sign up for the ER paperwork, you can do a telemedicine and prevent the ER visit potentially, right? There's so many other things. There's a chatbots. The secure messaging within the smartphone can be used for chatbots, and I'll show you an example later on. There are 265,000 medical apps right now built within the iTunes framework, right? So those are all the apps that are here for us to actually find a good use case and actually deliver the modern science which we want to. So looking at different streams of digital medicine, let's look at the app landscape. 265,000 medical apps. What are they for? Bulk of the apps are for fitness, wellness, or medical references. But really the apps which are most meaningful for us for healthcare value transformation are those which do medical condition management and some kind of a remote consultation or monitoring, right? So let's focus on that, because this remote monitoring is becoming the standard of care in certain diseases, including diabetes. In fact, WellDoc was the first app ever to get approved by FDA. And it is very interesting, the conversation that happened before FDA approved it. When the proposal came to FDA, FDA did not have personnel to think about how an app can get approval from FDA. They were only doing drug and devices. So they said, we don't know what to do with it because we've never been approving an app. But then the data was so powerful. The data showed within 12 months, 1.2% reduction in HbA1c just using a remote monitoring device connected with an app for diabetes. And FDA looked at the previous approvals they did, and 3 months before, FDA approved a drug which took $1 billion to come to the market, which showed exactly 1.2% reduction in HbA1c. That finally convinced the FDA that you can have apps and remote monitoring, even without creating a new medication, you can actually achieve an outcome similar to a medication. And that started the field of digital therapeutics. Taking a leaf of telemedicine, now more states in US have telemedicine parity law, right? Aligning business case with the technology. We used to have telemedicine a long time ago, but now if you do a telemedicine call, you'll actually likely get reimbursed. Based on the insurance that it is, the amount may vary, but New York State already has passed the telemedicine law. And I'll give a very simple example. This happened last year, even before I think the telemedicine law got approved. I had a patient I had to see, she was pregnant and not doing good, but she was from upstate New York. It snowed heavily, she couldn't make it. So I converted my visit to a telemedicine and actually had one of the most gratifying visits, where she saved total of 10 hours, 4 hours coming here, 4 hours going back, 1 hour finding the parking, 1 hour going to the parking spot, sitting in the waiting room, and we felt we got exactly the same outcome we wanted if she would have come face to face, right? So there are multiple studies now in telemedicine where it has shown reduction in readmission reduction by up to a third if it is done at the right time for the right person. Like telemedicine, secure text messaging is gonna become mainstream. I would say, and we have some prediction for 2020, where we're gonna see telemedicine and secure messaging will be used like water. Like you pick up phone and talk, you'll be doing telemedicine. Similarly, you'll have secure messaging. And this was a very powerful study done by Australian researchers published in JAMA, where they showed just 4 text messages a week, and this was one-way text message, not even 2 text messages, in people with coronary artery disease, led to reduction, around 49% reduction in smoking cessation, and significant reduction in LDL, blood pressure, all just by 4 customized text messages a week, right? So technology, if done the right way and personalized for that patient, and so simple as a text messages, can actually have such a dramatic improvement in outcomes. You can also go beyond telemedicine, secure messaging, and see how all these fitness bands which are there, how can we integrate those into our practice. And there's a big trend of moving away from wearables to skin sensors, which we call as implantables, which can measure sweat level and other kind of activities, to digestibles, which you can actually swallow. So there is a company called as Proteus, which is FDA approved sensors which are mixed with pills. So you can track adherence real time, not only like a pill container which opens, but actually you can track when the person is taking. And a 4-week trial have shown that they can lead to hypertension reduction by up to 60% of the population within 4 weeks. So very powerful. And how this all technologies are converging together is in a very fascinating way. I never thought of this possibility till I saw this company's kind of a slide deck. This is a company from Israel called Somatics, and what it does is behavioral modification for smoking cessation. And instead of creating a new wearable device, what they do is they use the regular wearable devices and can predict whether a person is smoking just by the movement of the hands, right? Because they have an inbuilt kind of a gyrometer and all these movement devices, right? So now they can distinguish whether the person is eating from the person is smoking, whether the person is combing the hair, right, or shaving from the person smoking. And then they can give alert to the patient that you were, and through GPS they can say, hey, you were in workplace and you're smoking, which means there's some stress that's bothering you, right? So they can give those kind of contextual relevant information. Fascinating, right? And things are gone even beyond our imagination to virtual reality. And I was the first one to say this is like too much out there, right? People say that I am too much out there, and I was saying this technology is too much out there, we're never going to consider it. But my perception completely changed when I saw this. And I'll probably show you a little bit clip if it's possible. And this is a virtual reality which take patients who have burn patients from war veteran and take them to an immersive reality so they don't feel the pain when their bandage is going to get changed.
Tuck on my seatbelt, or open the door. I believe my guardian angel just took me out of the truck.
First Lieutenant Samuel Brown survived an attack on his Humvee in southern Afghanistan, but he would then have to endure rounds of surgery, skin grafts, and painful skin stretching.
This is a battle that's going to take years to...
Right. So I'm going to fast track it. Oops. Well, technology people always have technology problems. So it's okay. Are you getting there? Okay. So the last one actually shows how the snowballs are being hurled. This is called as distraction analgesia. Have you ever heard of this term before? Me neither. This is a new term coined by this augmented virtual reality, because you can distract a person who is, the snowballs are coming to that person, and through that there's an analgesic effect. They don't know the bandage is getting changed. So not only 20%, 15 to 44% reduction in pain medicine, you can see the MRI reports, right? So the first one is without virtual reality. You see all these signals in the brain which are activated because of the pain that they are going through during a bandage change. And then if you have this virtual reality immersion, you see how decreased the pain signals are. So now this, we are kind of testing these technologies and how to bring it for anxiety reduction before procedures, right? And certain other kind of things. So if you really take a step back and say, what do we feel in 2020 the digital care or our actual medical care would be? We feel virtual care, telemedicine, secure messaging will be ubiquitous, right? In fact, we'll see the advent of virtual hospitals and virtual medical centers where there will not be a single facility. It will just be a network of clinicians who will be just following the patients and doing documentation. We'll see 24/7 tracking, remote monitoring of all those critical patients, diabetes, heart failure, IBD. It will become mainstream. We'll see population health predictive analytics, so we can proactively say these patients are going to fall through the cracks because these patients are using an app for meditation, or they are suddenly their voice quality has gone lower, so they may be getting into a depression. We'll started seeing not only technologies but empowering of the patients. We'll be having a social determinants of health. Can you believe we do not have, we did some study and I'll share that with you, the single most important determinant of quality of life among patients with IBD was their education level. And we have no field within our electronic health record, at least no structured field, where we can capture social determinants of health, like health literacy, like education level. How can we decide to disseminate a health education pamphlet, which is personalized by the person's learning, if we don't know what their education level is, what their health literacy levels is, right? So now you can capture those social determinants of health, and you can have a peer network which can engage with each other through organizations like Patients Like Me, and those are going to become very empowerment tools. And we're going to see prescription of apps, prescription of telemedicine, secure messaging becoming mainstream. And we want Mount Sinai to be the first one to take that into mainstream. So the question is, all these fascinating technologies are coming, most of them outside our health system. But how do we take into our health system and really fulfill our objectives of a better outcome, but also value-based transformation? So we worked on this as a digital medicine. Dean Chani put up a team to say, let's look at 5 years horizon for digital medicine. And Bruce Darrow, our CMIO, is here, led this team. And we came up with this concept of digital Dayz, right? So these are like 5 petals. And the goal is these 5 petals work synchronously to create a very unified experience for our patients called as a digital experience. Patients do not care, and I'm borrowing words exactly the same as what Bruce Darrow says. So if I diverge, just excuse me on that. So patients do not feel, they do not care about the underlying technologies, right? All they care about is they have a problem in hand, and what is the easiest way that problem gets solved, right? So for them, the front-end experience should be completely streamlined. We can plug in all the technologies on the back end, but they have to interdigitate in such a seamless way that patients do not have to go from one platform to other. And so let's talk about few of these technologies, including endeavors that are happening within Mount Sinai. So first, there is a big initiative for telemedicine. In fact, we signed up a contract, a multi-million-dollar contract with a big telemedicine vendor. And what the concept is to actually deliver a Mount Sinai Express initiative, where no matter where the patient is, who the patient is, they can access to care, sometimes the same day or urgent care, even if we do not have our own physicians at that time available. We can actually get outsourced physician as part of this package. And if we don't have bandwidth to do an urgent call, we can have someone, a clinician, who can triage the call, either through a secure chat or through a telemedicine if our ED are full, right? So we are able to deliver on-demand care to no matter which person it is, which patient it is, no matter where they are, no matter what their problems are. And we've also started building our internal capacity to build apps, to test apps, to know what is sticking, what is not sticking within our population. And that's some of the work we've been doing over the last 5 years at App Lab. And it was the second App Lab in the country housed within a health system, where we have a team of data scientists, user interface designers, app developers, all working with the clinical team, but not in a startup company, but within the premises of a health system. And over the last 5 years, we had really, we were fortunate to have a multiplier effect, where not only we had a core team, many of the people from our core team are here, but we had some fabulous collaborators. And this is our innovation, Mount Sinai Innovation Champions Group, which is from all different divisions of medicine. And when we started, not a single division had any mobile apps or any digital medicine toolkit. And now each one of those divisions have some kind of a toolkit which they have either tested or they are testing right now. And within this ecosystem, we have more than 25 plus funded projects, 100 plus investigators served, and a whole community of digital medicine scientists created within Sinai and also outside Sinai as well. And working closely with our 4 executive sponsors, we have Mount Sinai Innovation Partners, we have IT, Department of Medicine, and CTSA. And this becomes a learning lab for us to see what is working, what is not. And if things are working, then we can scale it along with our executive sponsors. And I'll give a few examples here. We talked about remote monitoring. So this was a remote monitoring app, both on Android and iOS, we built for IBD patients. And the major challenge we were trying to address was exactly the finger on the pulse problem. We have around 6,000 IBD patients, 5,000 or 4,500 we actively follow within our IBD center. At any given time, we do not know which of those patients do not have controlled symptoms, which of those patients we have to proactively reach out and actually address their symptoms. So we created this and we tested in a randomized controlled trial. It's still in the final phase of the clinical trial, but we track not only the quality of life and symptoms, but we can actually track the quality indicators. These are the same quality indicators which are going to be very useful for meaningful use for MACRA and MEPS. And the platform is disease agnostic, so we can convert this platform into other chronic diseases, for example, for heart failure and allergy. And what is really good is patients get customized alert once every 2 weeks to fill a 10-item questionnaire. And all this data comes back in a dashboard, which our clinical team, we have a coordinator which looks at that, and they can easily filter patients who are doing good versus patients who are not doing good. I'm going to share some of the interim data while we're waiting for the final data to come. We have seen within 5 months improvement in quality of life among these IBD patients. And more importantly, our primary outcome was the checklist of care. We have started seeing 28% improvement in the quality indicators versus 9% in the control arm within 1 year of the implementation. We have implementations of this going in 5 hospitals in Canada. We have partnerships in 3 or 4 health systems in US. And the goal is, as we do the full clinical trial, we can expand rapidly to other health systems. But what is really fascinating is to having a close look at the data. And data is so empowering, and this is what we call as a new data. This is the data which has not been traditionally available for us from electronic health record. When we started looking at the quality of life data for IBD patients, and I want to be sensitive of the time here, we compared with University of Pittsburgh Medical Center. That was a 5 years data collected on paper for around 1,500 patients versus real-time data that is captured by the app in East Harlem population, right? And when you compared all the domains of quality of life, Mount Sinai is purple and pink is University of Pittsburgh, you see exactly the same pattern, right? In fact, when we talked with our Mount Sinai innovation partner, they said, you should copyright this. I said, you can't copyright data like this. They said, this is amazing. Data coming from a smartphone, real time, in East Harlem population is showing exactly the same pattern as in rural Pennsylvania, collected over paper over 5 years. And what is even more fascinating is the fact the two domains which had the most impact on quality of life were not GI symptoms. Those were psychological fatigue and tension, right? So when I presented that in a GI conference, I said, oh my God, we are missing completely the mark. We are treating just narrow GI symptoms. We are not treating other domains which are really impacting the quality of life. So gastroenterologists, being gastroenterologists, they are very smart. They stood up and they said, Ashish, you are missing the mark. We are treating our patients so better that all their GI symptoms have gone away. So the only thing remaining is what we have now been trained to treat, which is psychological symptoms. I said your point is well taken. How about we bring on the psychological apps, right, to treat our patients even if we don't have expertise. So we partnered with the cancer behavioral psychologist here, Guy Montgomery and Julie Scherer, who actually came for the grant effort, and they had some fascinating data to show that you can reduce cancer pain by doing some kind of a hypnotic therapy, which is basically you immerse the patients into different kind of a sound and visualization tools, and you can track what were their outcome before and what was their outcome before. So now what we are working on is we developed this app called Health Hypnosis. Now we have a toolkit to give to our IBD patients, right? As soon as they go low score on depression or anxiety, we can auto-prescribe them this app and then see if they have got a meaningful improvement. If they have not got a meaningful improvement, we can do a telepsychiatry prescription to them. And if that doesn't work, we can actually have them come for an in-office visit for multiple sessions, right? So the same remote monitoring concept can now be expanded to things like heart failure, which is a very big problem for readmission reduction, right? So we have this, the same platform, Health Promise, now is connected to wearable devices. So we can get the patient's blood pressure, the patient's weight, post-discharge every day. They just have to step on the Bluetooth connected weighing machine, the data comes to us. It does two things. First, it tells which of the patients are compliant in checking their blood pressure. And believe it or not, that is the single most important predictor whether they're going to control, they have a control symptoms of their heart failure. This is very early data. This is a 6 months quality improvement project. We have only the second month data. We are seeing reduction in readmission around 1/3 of the traditional readmissions we had. We don't know that's because of the eligibility criteria we had, because some of the patients early who were Spanish speaking, we didn't have the Spanish language app, and I would say 20% of the patients did not have a smartphone. So we have to take care of those in the modeling, but we are seeing 7.3% heart failure readmission rate as compared to 23% if patients are following this through this app. Similarly, we partnered with our hepatology teams. Hep C is one of those diseases which has come from only half curable disease, 50% cure rate, to 92% cure rate, all within the last 5 years. And it is creating a unique problem because we do not even have enough providers to treat hepatitis C. And it is a time-sensitive issue because if we don't treat all those people, they're going to land up with chronic liver disease and cirrhosis, a major cost burden. So we created this app which has decision support built into it. So patients or clinicians like primary care providers can just plug in few numbers about the patient. It will tell them from all those 15 medicines out there in hepatitis C, which of the medicines are really applicable to that patient. And the primary care provider get empowered to actually prescribe them the medicine, which they never had the empowerment before. We do have a backup of telemedicine with the hepatitis C specialist. So if there's any complicated patient that comes with cirrhosis or what have you, then there's a telemedicine call that can happen. We're doing a trial connecting this platform of Hepatitis A Cure, which is actually implemented in, I think, 7 federally qualified health centers with wireless pill monitoring device. So we can track when a person is opening this $80,000 medications over 12 months and whether they are taking the right dose or not. We've also gone beyond apps, and that's totally based on the community here, which comes with the problems, and then we try to solve the problem. This is a very fascinating project run by Matt Galsky in cancer, and there the challenge was in the bladder cancer, muscle invasive bladder cancer, there's a lot of studies to show neoadjuvant chemotherapy before cystectomy is preferable than cystectomy alone. But time and again the studies have shown that it's not being offered to the patients, partly because there's no tool to have a shared decision making with the patient because patients really get shied away with taking chemotherapy and the side effects. So they did a multi-model assessment based on all the data that was there, and we came up with creating a visual tool. So patient and the decision maker, the clinicians, they sit together and plug in 5 numbers. Based on that real time, decision support comes to them, which shows what would your outcome be with cystectomy versus what your outcome will be with neoadjuvant chemotherapy with cystectomy. And this is something that we have built in such a disease agnostic way that now we can take this platform and do it for multiple other diseases for shared decision making. Now, not everything has been fancy and delivering good news. In fact, the biggest things for us are the lessons we learn when things are not going very successful. And I think it's very important to focus on things which are not always successful. And this was one of the projects we have with our quality improvement team in medicine on DVT-PE, on readmission reduction and bleeding risk reduction. And this was an app, health education platform, and a secure messaging solution. And I think we went a little overboard in providing all those different things. And first, the patients were a little older, so some of them did not have smartphones. In the first version, we did not have a Spanish version, so we lost 20% patients more there. And then they found too clunky to actually download 2 different apps. And that is a major bottleneck that we have found, that just because there's an app doesn't mean the patient will be able to download it because they have to find from the app store among all those million apps which are there. And the second part is we ran into the problem, many patients do not have enough space in their smartphone to download an app. So we learned from this, and we are now coming with the concept of micro apps or mini apps. Mini apps do not even have to be downloaded. They are like bots. They come do the job and they just go away. You don't ever have to download them. And the same concept is in the text messaging platform, where you do not have to necessarily download them. You can actually engage with the physician. You'll be very happy to know, if you are not aware, Mount Sinai signed a contract to bring a secure physician-to-physician communication platform called Curator. So very soon you will not worry about $1 million penalty that you have to go give when you violate a HIPAA, when someone gives you a patient information on your text messages, which we do all the time. But all of that will be in a secure messaging platform, and this is going to be a game changer in terms of communication. Now Epic is also coming with some communication tool, so we'll see how much we go with Curator versus the Epic tool when that becomes available, but this I think will be a big relief for all of us. We have worked internally to provide a secure patient communication tool for patients to physicians, especially for patients who are very high risk patients, and I'll show you how we're going to be using that in a video very shortly. So we have gone away from quantified self, this crazy concept that came in West Coast, that you have to measure everything from your saliva to spit to skin to whatever, and we are kind of data donors and kind of liberating the entire world, which only happens in West Coast, to pragmatic East Coast, right? where we take all those best technologies and then we say, hey, this is how we're going to do it and make the maximum business case out of it. So we're seeing this from quantified self to quantified population health. And all those tools we've been using for clinical care and testing are also very applicable for research. In fact, the same tools, if you just turn it around, can actually do a fascinating way of supporting our research. Evidence building has been one of the most expensive things we do in research, and I'll share just few examples of research that we are using digital medicine technologies for. We presented this in Epic conference, where we took a cloud-based process, a very easy way. Within a week, we can develop a registry on the fly, integrate with Epic, so researchers can actually get any kind of data they want in a structured format for any registry right within Epic. So there's a button called App Portal. If you click on that, it passes on patients' parameters, converts them into a research ID on the fly, and then all the other fields, you can fill it, right? So this is our process of having a same workflow, but you can actually run a research registry right within Epic. We now have 2,000 patients into our Crohn's and colitis registry, and we can combine data from DataMart, from Epic, with our registry, with app-based data and data that's in our colonoscopy record to create a unique fingerprint for every one of our patients in IBD, which are in the registry. This was the Asthma App, which was led by Yuan Chan and Eric Schatz's group in genomics, and this was featured in Apple Keynote. And this was an asthma app, so patients, a research app, patients can track their symptoms and can then see what all asthma flares are happening in their vicinity and can actually manage, track their medications as well. Within a day of it being launched in Apple Keynote, there were 12,000 downloads. And recently, Yuan Chan published a paper in Nature Biotech, which showed the data from this asthma research kit app that had very positive correlation to areas which were having fire and smoke hazards. So these are not Mount Sinai patients. These were open for everyone. And this is just a very fascinating way you can do research, even reaching out to patient cohorts out there. We have a patient clinical trial recruitment platform, which is now approved by IRB for health system-wide use, where you can plug in, just upload your IRB's submission. It parses that content and makes it very patient user-friendly. This can be available as a widget on the website, but really what we have done, and we are still testing this part, we have created a clinical trial bot, which can in natural text talk with the patient and enroll them into relevant studies, or it guide them to the relevant study. So let me see if I can show you a quick demo. I may have to go out of this presentation mode. I'm sorry. And this is a computer that is talking with the patient, or a bot. And this is completely natural language. And it's asking the patient, how old are you? And it's running the engine based on what eligibility criteria we have fed for the clinical trial. Then it's asking what kind of IBD you have. And then it summarizes them, what is your age, what kind of IBD you have, and it gives them a link of all the clinical trials the person is eligible for. So this is our relationship with Microsoft. We are testing and providing input on that and kind of baking our algorithms into it. Those are my kids, by the way. So like we talked about the clinical care where it's going in 2020, we can envision where the research is going to go in 2020, right? So we're going to have e-hypotheses. What that means is while you can come up with hypothesis when you're sleeping, you can also mine the data from electronic medical record from all the apps to actually come with very relevant hypotheses that need to be tested. With apps like ResearchKit apps, you can get data and then do hypotheses. You can do feasibility trials. What eligibility criteria will yield maximum recruitment rate running from the clinical trial, running data from the EHRs and from the apps. You can recruit patients. You can do e-consent from the patients. You can randomize patients electronically. You can actually run the entire clinical trial virtually. There's a whole concept, a whole field, like we're providing virtual care, you can provide a virtual research study completely running through all this technology. And a lot of that is we want a playground for us at Sinai, so residents, medical students can learn from it and actually get a hands. This is not rocket science. One of the biggest satisfying gratification factor for me personally has been, unlike Epic where we are logged into a certain technology framework, this is completely liberating. It's like a playground. We can create something which we really feel is needed, tinker with it, and perfect it if that is what we want to take it, and make this toolkit available to all of us so we can play. So I want to make a plea for Sinai MedMaker Challenge. This is our second year running. CTSA supports it in Sinai Innovation Team, and we partnered to actually provide this toolkit of apps, analytics, and also wearable devices. So all of us can get exposed and create some mini solutions we want to. While everything looks great, I also want to talk about one single challenge which none of us single-handedly can address, but we all have to address as a scientific community. And that is the challenge of evidence, right? There's so much innovation happening in this space that we do not even know what is working, what is not working. And just giving few examples, this is called one of the pillars of cardiology, Eric Topol. He's the first dean of digital medicine. Digital medicine is becoming a specialty. They have a whole division of digital medicine at Scripps. He's the dean. He ran a trial and found no absolute difference improvement in outcomes in remote monitoring of patients with hypertension, atrial fibrillation, and I think the third one was diabetes. Study published last month from UPenn actually showed that there was no improvement in patient adherence or outcomes of patients who were admitted with acute MI if you give them a social support, a kind of a gaming scheme with lottery so they can get financial incentive, and a connected pill bottle, right? And the major gap here was this was done by a managed care plan. So patients felt this was not their clinical team which was giving and running it. And they were corresponding with their clinical team while in parallel this health management plan was running this kind of a lottery. So I think there's all of these negative things, negative trials that actually we have to see what is working, what is not, and what are the lessons learned which we can feel better. But on a good note, there are things which we never felt will be working, which actually are working fascinating, right? So Pokemon Go is considered the biggest fitness craze. We had a backyard party, my kids were running all over the place, and I said, to my son, what's going on? He said, Daddy, you never told us. There's so many Pokemons in our backyard. So I never knew that till they told me, right? So we're trying to address this evidence challenge in two ways. One is we have to come together, and it's not just within Sinai alone. We have to bring all those health systems who really care about unbiased evidence. And we have created a consortium of 25 health systems called as the Node Health, which is now, the mission is to actually share all the things we are doing and actually do trials in a much more scientific way. The goal is to take all the innovation in digital health, combined with the rigor of evidence-based to create a new field of digital medicine. It's all evidence-based. We've been very lucky. We actually now have a journal, Digital Biomarkers, where we have a way to publish our studies as well. And we have a 2 years free rights to publish anything for free of cost in this journal. This is our first paper as a Node Health Consortium that got published in the journal. And these are the organizations that are part of the organization. And I'm very happy to say we are doing the first scientific conference exclusively in digital medicine here in New York City in December. So we'd love to have you, and we'll have representation from most of the health systems, 25 health systems. We were creating this new discipline and sharing the evidence of what is working, what is not working. The other challenge we are trying to solve for evidence, the other approach is, how do we take all these 265,000 apps, find the best apps which we have, and really provide a platform for you to prescribe those apps to the right patient at the right time, right? Talking about the challenge we faced when patients had to go through the app store to find the relevant apps, right? There were 15 minutes spent, and a lot of the patients we lost there. So we have created a platform here. In fact, Mount Sinai is the first health system in the country to have a platform to prescribe apps. So we did a trial here in October in 5 sites, and our goal was to prescribe 100 apps within 8 weeks. We ended up prescribing 2,000 apps within those 8 weeks. So the time is now to start taking the best, most meaningful apps for each of our specialty. They have to be meaningful, and they have to make a difference in the patient outcomes. Otherwise, it's just another tool out there in the pocket. But if we do it, we can make big difference. All of us are using Epic. How many love and think, oh my God, today is the best day. I'm going to open Epic and really looking forward to it. How many of us enjoy going to EHR? Okay, my hand is the only one standing. But look, we did a usability study of this platform, and we found 96 percentile score. So of all the technology products, including major apps, including device like iPhone, this RX Universe platform is 96 percentile, just because it's built within a health system, and it's simple. It just does what you want, click of a button, and not only you can click of a button, prescribe an app to a patient. I was talking to the chief residents here. You can click of a button and prescribe to the entire population of patients. So if you have 5-item questionnaire for asthma control test, and you want to give it to 50,000 patients, you just upload those 50,000 patients information, you click a button. While you are sleeping, they will have a link of this 5-item questionnaire. And suddenly you can see which patients are controlled, which patients are not controlled. And you can actually do the entire population management based on that. I don't think so we'll have time to demonstrate the tool to you, but we have created different widgets for procedures where maybe, let me see if there's a time I'll play in the end, where you can prescribe the app, the patients get a text message, and it gets timely reminders, and we're going to turn it on for colonoscopy first, and if that is successful, we're going to make it available for nearly every procedure that you want to. And we are coming with this concept of digital medicine toolkit. It's not just apps, right? It is health education content. You can prescribe it. You can prescribe e-coupons for discount of drugs. You can prescribe telemedicine link. You can prescribe wearable devices. You can prescribe patient experience survey. You can prescribe appointment scheduling, all bundled into one digital medicine toolkit for your specialty. This toolkit is now being used for a national registry for 60 centers for fecal microbiota transplantation. And the study coordinators will be prescribing content about stool transplant for patients who will get it. And the app will track them over 10-year period, how they are doing. And partly because the team never had enough money to have coordinators to follow the patients for 10 years. So they had to automate the process. And we're leveraging now app and this digital medicine toolkit to actually track the data over 10 years. It's like a Framingham cohort, but just on stool transplant, having in 60 centers. I want to really thank our collaborators. Many of those are here. Our executive sponsors, Bruce Sands, Barbara Murphy, Bruce Darrow, Kumar. Without this, will not have been where we are in 5 years. And a lot of these internal collaborators who actually come with such fascinating ideas that energizes my team, and we then work together and kind of try to build solutions that make an impact. And I'll end on this note. Digital medicine is medicine. It's not different than medicine. We're going to be using it like water, like every day in our purpose. And the technology is ready. The question for us is, are we ready? Thank you so much.
Thanks, Ashish. We'll open for questions. Just ask, what is it like for interoperability across institutions? What's the landscape nationally?
Yeah. So nationally versus regionally.
Yeah.
So I think there is still emerging standards, and now that's been working for the last 20 years. But there is a standard called as FHIR. Like New York has a New York Health Information Exchange, but FHIR is a standard which I would say sometimes you need a very big catalyst to implement that standard and make a game changer. And what we feel Apple is coming and including those standards and liberating it through patients. So I would say next 6 months to a year will be the most fascinating part for interoperability. If those tools get unlocked through patients, through big behemoths like Apple, we're going to see a major game changer in interoperability. It may be through patients. Patients will have their data, and they will have data for other specialty data, and they'll be able to merge those records.
Other questions? Yes.
Ashish, you talked a little bit about outcome measures, but perhaps those long-term measures in certain contexts are inappropriate. Like a simple outcome measure might be, once the app is downloaded, how often does the patient use it?
Very true. Very true. So as part of this platform, we have API. So in fact, I didn't get a chance to show you. When we send patient a link, we track every link the patient is clicking. In fact, when we give text messages with links for colonoscopy, we can actually create an engagement score. How many text messages the patient is clicking. And if they haven't clicked, then we can actually tell this patient may be a risk for not coming. And through the API, we actually get the data back for either our internal apps or the third party which are partnered with us. So we get two kind of data. We get data whether the patient has successfully logged in. So we consider that chapter at least done. And then we get the last time they have logged in and the frequency of their login. That's a very relevant question because everything is like dose response. Like in medication, you have to give the right amount of dose of medicine at the right amount of frequency to achieve a desirable outcome. We're seeing exactly the same in digital medicine as well.
Yeah, I'm curious about the process for approval. So you mentioned that there's the FDA approval, which is a great landmark. But in terms of how many apps any individual's going to have, and maybe that they'll actually have competitive interactions. If one works and the other doesn't. So
that's correct.
How are we going to regulate
right.
The adoption of these things?
Right. So I think FDA is looking at only a fraction of the apps, which mostly devices are apps which are voluntarily there. Most of the apps which we are building we have showed here come under jurisdiction of FDA but not mandatory approval of them. So we have to have some other approval processes. You're absolutely right. There are 2 or 3 initiatives going on in US. There's Exercia with AMA where they are going through some app guidelines. What we have done is there's some published evidence on reviewing apps and we are just ranking the apps based on the evidence and leaving up to the health system leadership to decide where they want to draw the line, right? So for example, if you want an app in asthma, and there are many apps in asthma, you want to have a stricter criteria. But if you want an app in suppose something in OBGYN, and you have only 1 or 2 apps, you may loosen your criteria. So what we are looking at, instead of we saying this is go, no go, we are putting a sliding scale to it with the metrics that they have to have at least 1 published study, then they make the cut. So you have to have something like that.
Okay. All right. Thank you.
Sure.